Well, hello, everybody.
Hello.
Welcome to the evening. Any luck, I can manage to not trip over these things. Create a problem. So, my name is Luke. I'm a physical therapist. You may not have seen us here in Mineral Wells before. We opened up here in March of this year. Great time to open up a new spot.
Good time.
Honestly, it has not been that bad for us. Right at the beginning, we were termed an essential business, so we haven't been aggressively pushing or anything like that, but we're also not going to complain. It could have been much worse for what we do. So we're going to talk about rotator cuff and shoulder pain. So right off the bat, the first question is, who's had shoulder pain in the last 30 days? And I raise my hand because I'm a member of the Shoulder Problem Club myself. So when we talk about the shoulder pain, one of the main things we want to know is what happened to cause the shoulder pain. Normally, there is something that you do, whether it's, and I always use an example as a postal carrier, rural carrier, reach in the back of the car to grab the mail, to reach out. Those folks have such a hard time, they do that all day long. It's just really tough on the shoulder. But inevitably, there's something that we do that is responsible for aggravating that pain. For me, it has more to do with how I sleep at night. I'm one of these sleepers. Not the best thing for a shoulder. But I can usually identify that, or I've been doing clearing some land. If I'm out doing a lot of hard, aggressive stuff that at my age is a lot harder than when I was 20, then it talks to me a little bit then. So I know what mine does. And specifically, how bad was the pain? 0 to 10. 0 is no pain. 10 is your worst imaginable. I've been fortunate. Now, this past month was a little bit worse on my shoulders. The prior 6 or 7 months weren't too bad. So my pain, probably it was maybe a 3. Not terribly bad. As long as I wasn't doing stupid stuff, it wasn't that bad at all. So as we go through this, I want you to be aware and think about what your activity is, what you do that creates your shoulder pain, and then how bad is it? So who am I and how did I come to specialize in shoulder and rotator cuff? Well, quite honestly, where I really learned what to do here was by dealing with my own. So my first experience with shoulder problems, high school football. I go in on one play, and I'm playing defense, so I go to make a tackle. Somebody lands on my shoulder, dislocates my shoulder. Well, you go out to the sideline, they pop it back in, and you go back in the very next play, the same thing happened on the other side. Well, same thing, you go out, put it back in, and you keep going. That's when you're 17. Fast forward 20 years, and all of a sudden, you've got some issues that you got to deal with. And so that's where I really learned to apply what I know as a clinician, as a therapist, how to do it, because I've had to deal with mine. So a little bit about my education. I've been at this a little while. I graduated from Texas Tech in '94 with my physical therapy degree. About that time, they started changing the degree from a bachelor's degree to a master's degree. For about 10 more years, and they started doing it all as a doctorate degree. So I had to go back to school to get a doctorate degree went to MGH in Boston to get mine. I did learn a lot there, but I'll be completely honest, I went back to get that so that I didn't have 23-year-old doctors that I employed giving me a hard time about it. So, but that's the evolution of what I do educationally. Along the way, some of my achievements, something that I'm extremely proud of is, and we'll talk about this a little bit, is I wrote and authored a form of dry needling. You're going to ask, what is dry needling? Dry needling is, let's say it's a form of acupuncture, but we're using Western medicine versus traditional Chinese medicine. I don't know anything about your yin and your yang or your qi or your life force. I don't really want to know. But we know how to take those same principles, or that same tool, and it elicits some significant change in muscle pain, in inflammation in the body to let us then start working things and doing things a little bit better. So I teach that across across the nation. Right now, most of it is online, which is not the best way, but it's the world we live in at the moment. Hopefully that'll change soon. Speaking of which, we've got a group of folks that are online that couldn't make it out, watching on Zoom. So hello to you guys. I will mention, if you didn't, if on the Zoom, if you guys do have questions, feel free to send in under, where do you want them to send that to? Just the
either chat or Q&A.
The chat or the Q&A if you've got questions. Likewise, if you don't have questions as I'm going, feel free, raise your hand, shout it out. This is about getting some information to you. So if there's some things that I can answer, feel free to yell it out. And from time to time, I will lecture across different colleges and universities on the dry needling piece. So with that clinical experience, these numbers are a little bit dated now. I'm in my 26th, 27th year, I forget the math.
27.
27. Over that time, I've treated well over 500,000 patients. I've also, with the dry needling, seen over 30,000 patients specific for that. With that number is way off. It's easily 250,000 individual needles that I've used. Again, we'll talk about the dry needling. It is one of the critical pieces that we use. If pain is elevated, we can stay away from the drugs, we can stay away from injections to get that stuff down. That's the key, is getting that inflammation down. And we'll talk more about that. So let's talk a little bit about the rotator cuff. Again, I'm going to try not to fall down. I told you I'd be standing over there.
You did.
Right here. So with the Zoom, we're really having to adjust and make some changes on the fly here. So rotator cuff. We'll start with the bones and what the bones look like. So the first bone that we talk about is the upper arm bone, or the humerus. Now, on your worksheet, absolutely, if you want to fill these things out, fill them out. I'm not going to grade them at the end. So the humerus, don't have to remember the fancy names, but the upper arm bone. The second bone that we get concerned with is the scapular, the shoulder blade. And that's the piece back there that moves all the way around. Thirdly is the collarbone, or the clavicle. That one's critical because of the entire upper extremity right here is the only bony connection of the entire arm to the body. That it's just one little location that connects. So although it doesn't seem like it does a lot, it's pretty critical in providing stability for the shoulder. Now, there's one other place here on this shoulder blade. So right out at the edge, and this is this spot right out here, is what we call the acromion. And we'll talk about why that gets important. But the majority of people who deal with the shoulder problem are also dealing with a problem related to this acromion and how it can really compromise proper movement of the shoulder. The joint itself, the upper arm bone has a ball on it, and over on the shoulder blade there's a socket, so we call it a ball and socket joint. It's surrounded by a balloon, if you will, that holds the grease, the synovial fluid in there. The shoulder itself is important as a ball and socket joint because the shoulder moves so much, it really resembles more of a golf ball on a tee. So if we talk about the hip is also a ball and socket joint. Now the hip got this big old socket like this, and then the ball of the leg bone, it's stable. It's not going anywhere. But the hip doesn't do all that much. It just needs to move a little bit. Up in the shoulder, I mean, we've got all of these degrees of motion, planes of movement, and so it really relies on the muscular control to make that work right. So talk about the muscles. 4 main muscles of the rotator cuff. I'm going to say there's actually 3. There's an extra one down here that I think it's kind of like the appendix. It's there. It meets the classical definition, but it's rarely injured, and it doesn't do a whole lot. But it's there, so we include it. So the very first one, the one that's probably more injured than any other, is the one up top. You don't have to know these, but that one's called the supraspinatus. And that is the main rotator cuff muscle, and it attaches right up top. The one below it, which is kind of the workhorse of the shoulder, it's the one that if we're doing a lot of rotating in and out, that's the one that gives us all of our pain right back here. It's called the infraspinatus because it's below the spine. The appendix of the rotator cuff is called the teres minor. It's just there. Don't have to worry about that one. So on the front side, if we have pain on the front up here, normally what we're seeing there is a problem with this muscle that sits on the front side of the shoulder blade up against the rib cage, and it comes around and attaches right here on the front, and that's called the subscapularis. So those four muscles comprise the rotator cuff. So what does the rotator cuff do? So we talked about this being a golf ball on a golf tee. Very limited contact right there. We have some ligaments in there, but they're not really what supports the shoulder. They're not what keeps the ball on the golf tee. So these four muscles, their main job is at the top, at the front, and on the back to keep that ball pulled into the socket. What can happen is, let's say, did a lot of overhead work. Let's say a baseball thrower. We're coming up here. More often than not, that upper muscle is going to be impacted more. We're going to get a little strain up there. Whenever we get a strain, what that means is we get a lot of muscle tension, a low-grade spasm, if you will. And so all of a sudden, this perfect balance of muscle up top, muscle on the front, muscle on the back is not quite right. So if this one gets really tight, in effect, what's going to happen is it's going to pull that upper arm bone up next to the acromion that we talked about. The problem there is it's going to butt up. So all of a sudden, when we lift the shoulder, we're doing this number. We're not doing this anymore. It just won't go any further. It can happen on the muscle on the top. It can happen on either of the ones on the front or the back. If it's the ones on the front or the back, instead of that being centered like it needs to, it'll be offset to the front or to the back. Then we're starting to talk about problems with wear and tear on the cartilage that's between the ball and the socket. So their main job is just to keep that ball sitting nice and snug in that socket. They do play a little bit of a role with the rotation. I mean, they're called the rotator cuff. But really and truly, we have other muscles that serve that function. Their main is to keep it stable. So we talk about a lot of different things that work together to make the shoulder work properly. First one is the neck. It's rare to have a shoulder issue and not have some sort of a neck thing going on as well. They just tend to go hand in hand, partly because of all of the muscles. So our big upper trap muscle, not only does it attach out here on the clavicle and on the shoulder blade, but it comes up and attaches to the base of the skull, and there's a lot of other small muscles that attach onto the neck. So we have to make sure that the neck is working right too. So if I've got an issue out on my right shoulder, which I do, then odds are I may have something in the neck as well, therapists are terrible. It's like the cobbler's kids have the worst shoes around. So mine's been irritated for a few weeks, and I've been trying to get around to having it taken care of, and I just never did until a couple of days ago. But I had a really bad crick in my neck and the shoulder thing going on. Needled it a couple days later, pretty good. So anyway, the neck has a big role in how the function of the shoulder proceeds. Partly it's because of the muscles that attach, partly it's because of posture, partly it's because this lower section of the vertebra, see 5, 6, and 7, those are the nerves that come out and give us our strength here. And so if we've got a neck issue, the problem in our shoulder may have more to do with the neck than it does the shoulder. Very common. The second piece is the collarbone. I mentioned that it's the only bony connection that we have of the whole shoulder, whole arm, to the body. And it connects, I've taken the sternum off, you can't see it here, but that connects onto the sternum right here. Every now and then, the collarbone, for lack of a better term, can get stuck. A lot of us have been to a chiropractor, and we get popped, adjusted, manipulated, whatever term we want to use. Myself, from time to time, will have to do an adjustment on the collarbone because if it gets stuck. Once we get to about here, if it's stuck, that's as far as we go. That bone has to rotate to let us go the rest of the way. So we want to look at that to see if there's an issue there. Maybe the shoulder issue is simply related to the collarbone. And then the shoulder blade. So we're out working, we're out golfing, we're out doing whatever we do. And the shoulder starts to get irritated. And that pain persists for a few days, a couple weeks. Before you know it, it's several months. Before you're stuck right here because the thing just hurts so bad. You try not to move it. And a couple of things can happen there. One, we can get what's called a frozen shoulder. But even if that doesn't happen, what does tend to happen is all of the muscles that attach the shoulder blade itself onto the body, they can get really stiff and really tight too. So whenever I'm working with the shoulder, one of the first things that I look at is how's that shoulder blade moving? Because if it's stuck here, if it's not moving up and down, then that's another problem. So several things going on here. Lastly, we talk about the rib cage itself. So there are, especially the first rib and the second rib, which comes to right here, and then we see it right back here. Because of their location, their proximity to the collarbone and the neck and the shoulder blade, they can play a real key role. And we'll look at it in a minute why that is. But one of the things I want to know is, how are those ribs working? A lot of the problems in the ribs actually can radiate out to the shoulder as well. So we've got a lot of potential things that can be shoulder problems that are actually other things. So whenever I look at these things, those four things I have to make sure to make so that we know that it is truly a rotator cuff problem and not one of these other things. Truth be told, honestly, it's usually a combination. There's usually, maybe there's a neck issue and a first rib. Maybe the shoulder blade is a little stuck. And then maybe there's a little tendonitis, a little bursitis, something like that going on in the rotator cuff. So those four things have to work together. So on your worksheet, again, I'm not taking score here, but since we're here, what is the rotator cuff? It's a group of four muscles that move the shoulder. One of these days, I'm going to correct that. It actually doesn't move the shoulder. It stabilizes the shoulder. It keeps it where it needs to be. It keeps the ball on the tee. It's a ball and socket joint. And the four areas that have to work together for proper shoulder movement is the neck, the collarbone, the shoulder blade, and the rib cage. I'm telling you, next time I'm plugging over there. So again, I'm in my 27th year here. We go to school, we graduate. I don't care what it is, whatever we do, we graduate. We think we're the smartest thing out there. We know everything. And I came out of school, and that's what I thought. Until my shoulders got to be a little bit more of a problem, and I had to relearn a lot of stuff to figure out how to take care of my own. So before I did that, our traditional physical therapy role. Shoulders in medicine are similar to backs. There just haven't been that great of outcomes with dealing with them. In my experience, 50% of the people that I saw for shoulder problems, they did okay. They got some exercise, got a little flexibility, got some strength, really didn't take care of their inflammation, their pain. But, they did a good job. There were 25% that we were able to just knock that pain down, get everything back good, and they were perfect and good to go. And then another 25% did extremely poorly and will have ended up having to have surgery. Now, as I look back, these are horrible numbers. That's like being the weatherman. If you can do it right 25% of the time, then that's no good. During the process of dealing with my own, I learned a lot more. And a lot of the advanced training that I took, a lot of the people that I took it from, really gave me a better insight in how to address what's happening with the shoulders, how to deal with the body. So once we start, especially with the shoulder, dealing with all of the pieces that comprise what the pain is doing, what's happening here, our numbers change significantly. anymore. Using my approach, 90% of the time, we can knock pain down considerably, we can restore function, and we can avoid surgery. There are still 1 in 10. 1 in 10, odds are you're still going to have surgery. There's some damage that's just not salvageable. This is usually where I talk about a patient that I had fairly recently. She had gone in to her surgeon. The surgeon's a friend of mine. Went into the surgeon, had an MRI. All 4 muscles of the rotator cuff were completely blocked. It was done. There was nothing that could be done. And so she really didn't want to have surgery. She was early 80s, and understandably in early 80s out. In early 50s, I don't want to have surgery, but I sure don't want it early 80s. And so we talked a little bit about how we can control inflammation of the muscles, how those muscles, their key role is to stabilize, and it's the role of the other muscles to move. So we started working with that. It probably took, it took a good 5 months. But when she started with this, I mean, today she's here, pain-free. That doesn't happen every time, but with diligent work, and the point I'm getting to is about imaging and pathology. We can have tears in the rotator cuff. We can have inflamed dorsal. We can have tendons that are inflamed. As long as we can knock the inflammation down, it's okay. We're built to wear. We're built to have issues that go on. What we want to know is, can we get pain down and can we get movement back? That's all we care about. At 10, yes, the system is perfect. You get past that and things are starting to change. So I'm a much bigger fan of these numbers. So again, one of the things we look at is your pain reproducible. We started off talking about what is it that you do that creates your pain. Reaching back here, reaching in the pocket. Any sort of thing can cause it. So that's the thing. If it's reproducible, then it's reducible. What we don't like is pain that's constant and there's nothing that we can do to make it worse. If we can't make it worse, then something else is going on. And it could be not even necessarily pathology. Sometimes when there's pain like that, then we start thinking about oncology and other significant issues. So back to the worksheet. If your pain, numbness, and tingling is reproducible, then it's reducible. We didn't talk about tingling, but because of the location of the nerves coming out, if there's a lot of inflammation here, you can get a lot of pressure on those nerves, and so you can even get a lot of this shooting, tingling into the arm. In the past 30 days, the worst pain I've had was, so for me, highest pain was probably about a 3. Wasn't terrible. It was nagging. It was annoying. And for me, I have pain again when I'm sleeping in this position, or if I'm doing a lot of work up here, which I really shouldn't do. And that's where I am. So it can happen again while you're sleeping, reaching overhead, lifting, getting milk from the refrigerator. I mean, that's amazingly heavy whenever you try to go do that. Putting the hand in the back pocket. For ladies, putting on that bra, this is a tough one right here. This is a tough one for me, and I don't put a bra on. Fixing your hair, getting back here to do that, or just getting up from the floor. Any of those things can be there. So if there's a cause, we can usually elicit a change, and if we can, there's hope. There's something we can do. All right, so the cause of a problem. I keep thinking about getting rid of this, but it illustrates a point. So any problem, it doesn't matter what it is. There are 3 things we can do about it. Number 1, we can ignore it. I use an analogy of potholes. So we had been living in Weatherford. We finally moved out to the sticks, if you will. While we were in Weatherford, we lived on the west side. For whatever reason, the city decided that the west side where we were really didn't deserve any road repairs. So we had a lot of potholes, especially on one particular incline right by the house. And so here, we're going to talk about it in relation to shoulder pain. So you can ignore shoulder pain, and it might go away. It might stay away, but it may come back. Odds are, unless it's just some soreness from overwork, it's probably going to come back. I know for the potholes, it's definitely going to come back. Another thing we can do about a problem is we can alter it. So with the pothole analogy, they can come in and they can fill the potholes in. Well, those potholes, we lived there for 7 years. About 6 months before we moved, they did decide to finally put some asphalt in those potholes. So on this incline, and it was a pretty steep incline, there was one really big pothole and then 5 or 6 small ones around it. Well, they came in and they put the asphalt in the big one, but they left the small ones. And so about a week after that, it rained, and of course, it was pointless. So they tried to alter it, tried to cover it up. With the shoulder, what are we talking about? Drugs, injections, or surgery. People ask me, am I opposed to drugs, injections, or surgery? Well, not necessarily. So I did have surgery on my right rotator cuff. I had surgery, and 3 weeks later, I went and played golf and blew it right out again. And so, well, I'm a therapist, which means I'm really smart. I know how to take care of this and it be okay. Which it didn't work out that way. But what I did learn from that, if I knew, and I was a therapist then, if I knew then what I know now, I wouldn't have had surgery. Wouldn't have it all. There were other things I could have done to manage that. But drugs can be okay short term. You don't want to manage, and I don't care if it's a shoulder problem, a knee problem, hip problem, any of the problems that we deal with, drugs can be okay to knock it down temporarily. But it doesn't need to stay that way. You don't want to stay on the drug side. Injections, they can also be okay if it's used to see if they can permanently knock that inflammation down. And if they can, wonderful. The problem with just doing drugs, just doing injections, or just doing surgery is there's a mechanical defect that's happening that's making this thing not work right. And so with the rotator cuff, if one of these muscles isn't working right, if it's too tight, if it's got too much muscle tension in it, then even after you do that, if the drugs wear off, the injection wears off, even after surgery, if you have surgery to correct it, you still have to go through the work to get it mechanically working correctly again. So again, it can help, but you got to do it with a little discretion. Finally, what do? We handle it. So we didn't live there long enough to see if they ever repaved the road. Actually, my mom lives on the next block. I know they haven't repaved the road, so they haven't handled the thing. Handling it for the shoulder means how do you get natural treatment, learn to manage your symptoms. My goal when I'm dealing with, well, any body part, but especially the shoulder, is to, number one, mainly, let's get that pain down to a tolerable level. When we get that pain down, then it's all about, can we get the proper flexibility that we're designed with, and can we get the strength to let it do what it needs to do. Anybody that has a shoulder issue specifically, any other issue as well, we're going to have some flare-ups. We're going to have things that happen. The challenge is in knowing what's happening and knowing what to do about it. Again, I blew my shoulder out again 8 years ago, nine years ago. My wife, she knows all that stuff. I'm not a random person. So now I rarely ever have a problem unless I'm really doing silly stuff. But I can manage it, and that's my goal, is to give people the ability to know what's going on and how to manage what's happening with yours. So on the worksheet, things to do when faced with a problem. The number one single biggest mistake shoulder pain sufferers make, they ignore it. And I did too. And then 3 things you can do about your rotator cuff and shoulder pain right now. You can ignore it, you can alter it, or you can handle it. Most people that are here aren't just here because they're bored and didn't have anything better to do and thought this was the way to get some entertainment. I'm not that entertaining. So we know you're in here somewhere. I'm going to advise you to handle it. Okay. We'll get to that. So 3 main causes of shoulder pain. We're going to talk about imaging just a little bit. So here's an x-ray of a shoulder. This is a fairly normal looking shoulder. I always tell people, and I was trained most recently, not to rely on imaging for what I want to do with a body part, a shoulder. I love looking at imaging. So this one, in a shoulder, what we look for, we want to make sure there's plenty of joint space in between the upper arm bone, the ball, and then the socket right there. That means the cartilage is still intact. It's got plenty of space. There's plenty of cushion in there. Then we look for things like spurs. I know that looks like a spur, but there's a ligament that attaches there. That's not a spur. There is a little bit of a spur up top right here, though. So may have had a separation at some point up there. But all in all, this looks pretty good, and I would expect that shoulder to be perfectly fine. The problem is, this shoulder can come into me and be at an 8 out of 10 in pain, but imaging says that it should be perfectly fine. And partly that's because we're not treating this picture. We're treating what's happening here in the shoulder. And a picture doesn't show inflammation. A picture doesn't show pain. So a little talk, some MRI studies of adults who have no shoulder pain, they've got no symptoms whatsoever, show that full 20% have partial cuff tears, and a full 15% have full thickness tears in the rotator cuff. For those that are 60 years of age and older, over 50% had no shoulder pain, and they had rotator cuff tears on their MRI, and they didn't even know about it. So we know we can have stuff going on. It's not the end of the world. We're concerned about the pain and the inflammation and the limits of motion. Study on professional baseball pitchers. 40% of them had either partial or full thickness rotator cuff tears, yet they had no pain while playing and remained pain-free even 5 years after the study. So I mentioned a patient that older patient had a completely blown rotator cuff. I know the surgeon is a good friend of mine, and I promise you, he doesn't want to go have surgery if he doesn't have to. Even if the MRI says there's some tearing in there, if he's not having pain and he can sit at the table and cut all day, he's fine. He doesn't want to go in there. So the translation there, if you do have some imaging and it shows a rotator cuff tear, shows some bursitis, shows some pathology in there, it's not necessarily associated with shoulder pain, so you don't have to panic. There are things we can do for it. Which brings me to my conversation about vomit and barf. So vomit and barf. Vomit is being a victim of modern imaging technology and a brainless application of radiological findings. So that is treatment based on imaging findings alone without any clinical correlation. I know a lot of good qualified physicians and surgeons, and I'm not here to bash physicians or surgeons, but I know a lot of them that will evaluate a person and never lay a hand on the body part to see what's happening. That is one of the worst mistakes that they can make. You've got to put your hands on them to find out what's happening. And so just looking at it in an image, the goal is never just to restore that picture back to normal, because it'll never be back to normal. It's what is the body doing? So that's the vomit and barf joke. I told you it wasn't that entertaining. So the three main causes of shoulder pain, and there are hundreds of potential causes of shoulder pain. I've lumped everything into three because this kind of fits the idea of how I treat. Number one, neck problems. Here we're talking about stenosis or narrowing in either the central canal of the neck or the lateral where the nerves come out. There we're talking about we can have arthritis, which is basically bone spurs that are also creating narrowing, or degenerative disc disease. And here the stenosis, it starts losing height and it compresses on the nerves coming out of the neck. So on these two pictures on the left, we're standing, we're just looking dead on at this person. They're looking this direction. And so this one I'm illustrating the nerve that comes out to the side. This nerve, again, C5, 6, 7, and 8 actually are comprised everything in the upper arm. And so this picture, some of the little triangle things here, is the best I could create to demonstrate some bone spurs.
What happened?
So while she's working on that, with the bone spurs, what tends to happen, again, it narrows that space down where the nerves come out. Very good. And so anytime we have compression on the nerves, then likewise we can have business shooting out to the arm. It's probably 60-40. Is the shoulder problem the neck problem, or is it the shoulder problem? So often, especially as we get a little bit older, it's usually both. So we have to look at that. On this other side, here we are looking, this person's looking this way. You need to flip that around at some point. On the picture on the right, they're looking this way. Anyway, so with that arthritis in the neck, we also get some compression of the central canal, the actual spinal cord. Enough compression there, enough loss of space, and then we can start seeing that stuff radiate out in here. So the neck becomes critical on knowing where it's coming from. The next part on the neck, I just put that in there, is the rib cage, specifically the first rib. And so why is the first rib so important? We talked about 5, 6, 7, and 8. Those nerves all come out and form the bundle of nerves that runs down the entire body, or entire arm. And you can tell here with the first rib, there's not a lot of space between that first rib and the collarbone. Whenever we sleep here, what tends to happen is that first rib almost comes up like a bucket handle. So in that case, if that's happening, we're closing down the space with those nerves right there. And if we get some compression there, again, then we can start seeing stuff coming out here. It has absolutely nothing to do with the shoulder. It's all about that rib, the rib cage, the first rib, and its impact on the nerves. Okay, with that, with the neck problems, we also look at limited range of motion. So the neck really does 3 things. It gives us this motion right here, flexion and extension. It gives us the rotation, looking left and right. And then it gives us this business of leaning this way to that way. 9 times out of 10, if you've got a shoulder problem and a little issue with your neck, the side that the shoulder problem is on is going to have some limitation in motion in the neck as well. They just tend to go together. So the second one, the impingement. Now, impingement covers a lot of things, and basically impingement just means it's a pinching down of the muscle. Most of the other things fall under this category. So we talked about the acromion, this little edge, this little piece right out here, and its relationship to this the big main rotator cuff muscle. Well, what tends to happen is you can, in this little picture right here, you can see there's not a whole lot of space right there. Now that's blown up really big. Really and truly, we have less than 1 centimeter of space in there between the ball and then that undersurface right there. Well, in there, we have this upper muscle that has to sit in there. We've got a big ligament that's right here that's taking up space. We also have 2 bursa right there. And a bursa is just it's a cushion. It's a fluid-filled cushion that in the event that the upper arm bone gets jammed up here, it's going to be a shock absorber. So if all of this stuff gets inflamed from some sort of an injury or overuse, then all of a sudden, this little 8 centimeters of space is jammed. And that's what the impingement is. Here we're going to have trouble reaching behind the back, slipping on an arm like such. Again, the space is very small, and that's before we even consider bone spurs. So in the shoulder, the most common area for a bone spur is right where the collarbone attaches to the shoulder blade, which is going to be right about here. And those things always grow down. And they grow down, what's there? Well, it's the rotator cuff, obviously. And so what can happen is if that bone spur gets worse and worse, is that as we do more things and as that stays inflamed, it can actually start to act like a little saw, and it can start fraying that muscle right there. All right, so if I can make this work right, this is just a little video that shows the relationship of the bone out here, the acromion, that upper rotator cuff muscle, and what happens, how close it gets whenever we See if I know how to do this. Apparently not.
Are you saying you work on bodies and not computers?
Correct. That's the computer person. Okay, here we go. So we're going to rotate around here in a little bit. And so you can tell as that arm goes up, there's not a whole lot of space. So if there's some inflammation, if there's some swelling in that area, there's going to be a lot of friction. There's going to be a lot of stuff jamming up. So we'll rotate a little bit here and see a little bit more. And rotate one more time. Then back. And so we don't have a whole lot of space right there. And like anything that gets inflamed, what happens if we sprain our ankle? It swells. So if we have that same sort of thing, if we have a strain out there and it starts swelling, all of a sudden, all of those structures are going to be jamming up right there. And that's what gets us into this business right here. There's just not enough space to get that there. And the more often that we do it, the more we try it, the more it's going to get more inflamed. It's a never-ending circle. Sort of. We can fix that stuff. So the third piece is poor posture. So I've got this little picture up here of this guy playing on his cell phone here. These numbers are really small, but with a normal posture, the head weighs give or take 10 to 12 pounds. So that's what we've got driving down here. As we start leaning forward, as this posture, we round those shoulders, as we get down here, that force, that vector force goes all the way up to about 60 pounds. So that's a lot of force transferring through that. And where does it transfer? It transfers at C6, C7, C7, T1. Well, that's exactly where all these nerves are that are coming out this way. So poor posture gives us a mechanical disadvantage up here, but it also has the potential to decrease the signal running up the nerves out to the shoulder. So I preach posture all the time, because it's incredibly important. So do a little example here. If your shoulders are horribly painful, don't push into pain. But what I want everybody to do is sit up nice and tall. And just sitting, I want you to bring those arms just as high as you're comfortable bringing them up overhead. All right, and then we'll bring them back down. Very good. Now I want you to pretend you're 13. And I want you to do this little slump thing that 13-year-olds do. And now I want you to hold that position and try to bring those arms back up again. And they just don't go. So the relationship of our posture from mid-sternum up is incredibly important on what happens with the function of the shoulders. So back to the worksheet. Top 3 common causes of shoulder pain. One is a neck problem. And lots of potential things there with the neck. The second one is impingement, actual compression of the muscle itself out here. And then thirdly is posture. Those 3 things are incredibly important. So what does successful natural treatment look like? Well, before we get into it, do I have this in here? I don't think I do. So around here, so on that back wall right there is kind of a mantra of mine and my whole practice. 3 phases of healing. Number 1 is controlling pain and inflammation. As long as pain and inflammation is on board, there's really not much we can do to regain strength. We can't tough it out. We can't do that. The body is going to naturally inhibit those gains. The second thing is restoring normal motion and functional strength. So once pain is down, well, we've got to get that thing as far back as we have to. My 82-year-old, she doesn't need this. I don't need this. I need to be able to get in my cabinets and everything up here. So if I've got this, I'm not going to pitch for whoever. I'm not going to be anybody's quarterback, but I can sure do everything I need to do. If I'm 18, if I'm 12 to 20 something or other, and I've got an active sports contract on the line, we've got a whole different talk to go through. But for most of us, it is definitely more about our functional things that we do. So that's number 2. I chased the rabbit for a minute. And then phase 3 of healing is in getting back to the things we want to do, whether that's riding a bike or I get a lot of cowboys, a lot of ropers coming in. And even at 50, 60, they're still wanting to get out there and do this. I don't want to, but whatever it is that your goal is, that's the 3rd phase. So what does successful natural treatment look like? Depending on the limitation of movement. We're going to have to put some hands on. We're going to have to move some of these body parts. If that rotator cuff has been out of balance, for lack of a better term, odds are we're going to have to do some movement of that. In some cases, it is an aggressive manipulation or adjustment. In some cases, it's easy stuff. But 9 times out of 10, if pain in motion is out of whack, we've got to put hands on to change some things. If pain is lower, so here we're dealing with definitely that phase 1. We've got to get pain and inflammation under control. Number 2, then we've got to move on to strengthening and stretching. Now, emphasize the strengthening part. Stretching is very important. I'm going to give you a few things that I do to keep mine under control in a minute. Stretching is important to maintain a shoulder that has some inflammation in it. There's a few little stretches that we can do that go a long way towards keeping it under control. But ultimately, it's about stretching to get the motion back and then strengthening to keep that rotator cuff nice and solid to keep that ball in that socket. Finally, if that pain is elevated, I'm going to say on the pain situation, if your pain is sitting, let's say it's a 5 out of 10 or above, we need something to break that pain cycle. Me as my own patient, I jump to dry needling very first thing because we can knock that pain down super quick. 9 times out of 10, it'll go that fast. Some people are very phobic, very scared of needles. Understand I was too. I still don't like it, but it works so well. There's something called a class 4 laser. I have one at the office in Weatherford. We don't use it as much as we use dry needling. Quite honestly, it's just not as effective. But a person that's really scared of needles will pull out the big laser, and we'll use that. But that's all about breaking that pain down, getting it down to a controllable level. Once we've got that, then we can do something about restoring motion. So, what to do next? Anybody over 5 out of 10 on pain? Up there a little bit. This is what I tell people. If your pain is if it's 5 out of 10 or more, you've already ignored your shoulder pain. You've already tried to alter it with drugs and other things. It's time to handle it. There, I'm going to recommend, let's evaluate it. Let's get something going to get this thing under control. For folks whose pain is 2 or 3, that's not terribly bad. 2 or 3 is, we'd rather it be 0, but we can function with 2 or 3. And folks in that range, one thing I do offer, we'll talk about it, is a free screen. So with a free screen, let's go straight to it. With a free screen, what I do is I'm going to take a look at your shoulder, going to look and see how it moves. I want to know what the strength is like, what the range of motion is. I want to poke around a little bit and see where the pain is. Where the location of the pain tells me a lot about what's happening in that shoulder. Then we want to know what we're going to do with the free screen consultation. Decide is there something that can be done to heal it naturally. Honestly, normally what happens is I'm going to say, I want you to try these 3 exercises. Go work on it for 2 or 3 weeks and see what happens. A lot of times that really lets you get to where you need to be and you don't have to worry about this stuff. I'll give you some tips, like I mentioned. At the end, if you decide want my help, then so be it, but I'm not going to try to sell you one. Whole goal is to give you information on what's going on and what you can do to handle it. Again, I described the situation with my shoulder. I should have had surgery in the first place. I did. I messed it up. It's worse now than it was before I had surgery as far as what it looks like on imaging. But we now know what we can do to take care of it, to let it keep functioning. If it gets flared, there's certain things that we can do. There's certain things that I do that don't involve needling or anything like that. So what's the difference between a free consultation and evaluation? Honestly, it's time. If you want to come in and talk to me and let's look at things, we're going to take 15 or 20 minutes. So I've got a staff of, how many therapists we have?
9.
We've got 9 therapists and a bunch of support staff. You might see me. You might see somebody else. If it's in Weatherford over here, you'll see me. We'll determine what that potential cause is. I've been doing this long enough. It's not going to take me a whole lot longer than 15 or 20 minutes to pinpoint what's going on. My other staff, they're fantastic. I love them to death, but they haven't seen as many as I have. But they're great. They're great. So we'll determine a potential cause. We'll talk about what successful treatment looks like. I'll give you some things to work on. And then you can decide if you want to, after you do that, to work on coming back in and let us take care of things if it doesn't get better on its own. For a full PT evaluation, here, if your pain is 5 out of 10 or higher, we really should do this. Here, we're going to identify the cause. We're going to apply successful treatment. If pain is that high, we're going to start the process of getting the pain knocked down. Normally, knocking that pain down, that part usually doesn't take that long. To be completely honest, 2 or 3 times of treating that, and that part is usually under control. Here, that may take up to an hour. It's going to take a good bit of time to go through everything. And then we're going to go ahead and put in a plan of care to break down what getting you back to normal looks like. It's always, we're human beings. We want a quick fix. I want a quick fix. Sometimes it happens. Sometimes we get that great quick fix. Pain is gone. The problem is, if you've been dealing with this for more than a couple of months, then you've got some muscle memory things that have set in. You've got some tightness. You've got some limitation of movement. And it's going to take longer to get it back to normal. We can almost always knock pain down super quick, but it won't stay if we don't restore movement and strength. That's the key to long-term success. I don't know how many slots I have. I've got Ashton over here. I've got Casey up at the front. If y'all want to get with one of them to sign up for a free consultation, you absolutely can do that. While you're thinking about that, y'all have been super great listening to me ramble on about this stuff. Do y'all have any questions for me?